Hello, I'm John Nichols, and I was an English GP for 42 years. And although I no longer see patients, I managed to keep pretty busy doing research and writing. Now, I'd like to ask you a question, which I think you will find interesting. And it has an answer that is not as straightforward as you might think. So here we go. Can the fear of lung cancer make smokers quit? So my little talk is going to be based on this question. Well, you might think that there was a good chance that a fear of lung cancer would be pretty substantial in persuading smokers to quit, but it's not that straightforward. Yes, the fear of meeting the grim reaper face to face as he shuffles along this road of cigarette stubs might be pretty powerful at times. And in fact, in Auckland, New Zealand, they developed a test, the asparagine test, which tells smokers what their risk of lung cancer is if they don't quit. This was developed at this hospital, shown by the downward arrow there, by Professor Rob Young and his team. And it's mainly genetic, this test. So in the first place, they take a Buccal swab, that is a swab taken from the inside surface of the cheek. It picks up cells from the inner cheek surface and they're used for DNA analysis. So the specimen, once it's been parceled up correctly, has to be posted straight away to a special laboratory for DNA analysis. And the Auckland team have clocked up 20 genes, 20 gene variants that influence lung cancer risk. So for instance, take number 4 down, interleukin A T variant of this gene, TT, confers susceptibility because it inhibits an anti-cancer gene. The next one down, interleukin 1B, the GG variant, accelerates cell division in cancers, and so on and so forth. Now, the genes below the red line have the opposite effect. They are protective genes which protect you against cancer, these gene variants, even if you are a smoker. So the Auckland team developed this formula, which is largely based on the genetic test. You subtract the number of protective genes the patient has from the number of risk genes. There are always more risk genes than protective genes, so it always comes up as a positive number, anything from 2 to 3 to maybe as many as 10 or more. And then you do add 4 if the patient has chronic obstructive pulmonary disease, COPD, which is a significant risk factor for lung cancer. Another 3 points if there's a strong family history of lung cancer. And I'm afraid another 4 points if, like me, you happen to be over the age of 60. Then the laboratory, with this information, gives you a risk score. In this case, the example is a risk score of 5. And on this graph, you can read off what your risk of lung cancer is compared with a non-smoker. In this case, it's 70 times the risk for a non-smoker. Oh, the non-smoker's risk is actually right down here, almost off the chart. However, many patients, in my experience, are more interested in knowing what their lifetime risk is as a percentage. And you can calculate that from the risk score. If you assume that the non-smoker risk is something like 1 in 200 or 0.5%, then, for instance, with the example we've just had of a score of 70 times the non-smoker's risk, that gives you a 35% lifetime risk. However, you have to take into account the difference between the risk level before the age of 60 and after the age of 60, assuming that that's a 20-year spell up to the age of 80. And then you have a formula which gives you a percentage risk. And you have to make an adjustment if there's a big difference between the number of years before 60 and after 60. But for instance, if it gives you a 50% lifetime risk, that's a bit like spinning a coin and saying, well, if it ends up heads, that means I've got away with it, as many smokers do. But if it's tails, that means, sorry, but you're going to have lung cancer and it's going to be really horrible. So the Auckland team tried out this test on a group of 99 hospital patients that they recruited, mainly from outpatients, some inpatients, who they sent out either with or without the risperidone test. So the test group on the right knew what their risk score was, and the control group on the left were just sent home with some nicotine chewing gum, minimal advice, and they were followed up in 6 months. And at 6 months, you can see there's a considerable difference between quit rate, over 25% in those who'd had the test and been given a little bit of a scare, and a miserable 5% in those that only sent home with the nicotine chewing gum. And there is a paper describing this experiment in the medical literature there. Now, we tried to reproduce the Auckland results on a group of patients from primary care in Epsom near London. So I'll call it the Epsom project. And you can see the quit rate for the test group was pretty good. It was even slightly higher than the Kiwis from New Zealand. However, we got a bit of a shock, the control group, because half the group were randomized to a control group who didn't have the test, was even higher. And we wondered what the explanation for that was. But it was not statistically significant. So we had to scratch our heads and puzzle out what was going on there. Then we did a sub-analysis of the test group, and we got a bit of a surprise, because if the risk was a very high score risk, then, these subjects on the right had a lifetime risk of lung cancer of 50% or more, all but one of them quit. Whereas those with a moderate to high risk and an average risk, they were certainly no better than the controls. And if you compare this group, the very high risk test results, with the controls, that is significant statistically. That does mean something. Though it's small numbers, and a purist in the world of science would say, you need to do some more research there to convince me. Okay. Well, why is it that the subjects with a risk score below 50% lifetime risk, still many of them carried on smoking? Here's an example. I've anonymized this. I've changed some peripheral details so the patient cannot be recognized. But this is the nub of the story is still there. This participant was a young housewife who was stressed by having to care for 2 mildly hyperactive small boys, aged 3 and 5. And at the 6-month follow-up was still smoking 15 cigarettes a day. When I told her that she had a 35% lifetime risk of lung cancer, she said, oh, only 35%? That's not bad. When I gave her, I said, well, it's not good either. And when I gave her an analogy of, what if I told you that if you carried on living in your present house, you've sort of 35% chance of being murdered in your bed. But if you moved to a house in the next road, the risk would drop to 1%. She hesitated for a moment then and said, "But doctor, that's completely different." "No, it's not. 35% is 35%, whatever way you look at it. How did she work that out?" Now, here's some more food for thought. If you combine our data and the Kiwi data from New Zealand, the very high risk group altogether has over 60% quit rate. The higher the score, not surprisingly, the more likely they are to say, "It isn't worth it, I better quit." But even the lowest, what we call the average risk score, gave you a quit rate of 13%, whereas the New Zealand controls were a measly 5% quit rate. However, if you then compare that with our controls in the Epsom project, it doesn't look quite so impressive, but it's still very significantly less than those with a very high risk group. So why was this? What was going on here? Well, in Epsom, we had the full works for smoking cessation. We had smoking cessation counsellors that they attended every week for 8 weeks to be checked up, to have counselling, group counselling, individual counselling, and they were tested for breath carbon monoxide, and they had tests for nicotine products in their saliva, both of which influenced them. And if they wanted it, they could be prescribed varenicline, which is a drug which completely blocks the nicotine craving that is a problem when you try to quit. If they didn't want that drug because of possible side effects, there was a range of nicotine products, including nicotine chewing gum, which were also available. So let's look at this globally, the seesaw of destiny, the balance between motivators and whatever it is that stops them from quitting, the demotivators. This determines success or failure for smokers trying to quit. So if the motivators win, they have a long life and a healthy heart, because remember, a lot of smokers die from smoking-related heart disease as well. If the demotivators win, things like all my friends smoke, it calms my nerves, it stops me putting on too much weight, these are demotivators, then there's cancer lurking in the undergrowth. So let's look at these motivators and demotivators in some more detail. Well, these are the motivators that we discovered from analyzing questionnaires that the subjects in the Epsom project completed. They did this at 8 weeks and 6 months. They repeated the same questions. And I've ranked them in order of their perceived importance so far as the patients involved were concerned, the participants in the trial were concerned. So the number one, the most important thing, was the support and advice they got at the weekly smoking cessation clinic. And that, of course, included prescriptions for varenicline to block nicotine craving. Number two was the cost of cigarettes, which smokers find so annoying. And I've got to save some money and kick this dirty habit. Number three, also pretty important, is the influence of pressure from the family, gentle pressure and loving support from the family who want them to quit. And only fourth was the risk score for lung cancer from the respiratory gene test. So it was important, but not as important as the other three. And close on its heels was the results of the tests for saliva, nicotine products, and the weekly breath test showing how much carbon monoxide there was going around their lungs, which they found pretty worrying, that, you know, that these nasty chemicals in their body. And it did helped to motivate them to quit, almost as much as the risperidone test. So these things, of course, were not available to the New Zealand group that were in the control group. Current health problems that relate to smoking were actually very important for certain individuals, but averaging it out, it didn't come that high, but it was very high for certain individuals, such as if they were suffering from angina and they were told you could have a heart attack any moment if you don't quit. That would certainly motivate you. A doctor's advice came quite low down, you see, not as important as you might think. And the influence of smoking restrictions at work or on public transport were perceived as being relatively unimportant. What about the demotivators? And I picked up on demotivators by taking extensive notes on all the individuals that took part in the Epsom project. And obviously, top of the list is nicotine addiction and fear of withdrawal symptoms, which is certainly significantly reduced if you have medication such as varenicline to block craving. But maybe never totally abolished, because you can't take varenicline forever, can you? Number two, anybody who's dealt with smokers know they have this optimism bias. It'll never happen to me. I get lots of exercise, so that cancels it out. Or, Uncle Fred, he smoked like a trooper and he lived to be 90, forgetting about Auntie Flo, who died of lung cancer at 50. Surprising to me was to find that post-traumatic stress disorder was significant. Any individual who's subjected to stress of this sort, post-traumatic stress due to an accident perhaps, due to something bad in their personal life, finds it very difficult to quit, and more of that later. And the old perennial anxieties about smoking cessation and weight gain. A middle-aged woman decides it's time she quit, but then she puts on weight and thinks, my goodness, I can't afford to put on any weight. And so she gets back on the ciggies to control her appetite and weight gain. Side effects of smoking cessation therapy are pretty important. And this is the other side of the coin when it comes to prescribing varenicline, because if you have nasty side effects from varenicline, rather than getting the benefits of blocking nicotine craving, you think, oh, heck, I can't be bothered with this. And you just give up completely, as happened with one of my patients. And he also was an example of the next one, which is fatalism. He said to me, if it happens, it happens. I've got a pretty miserable life anyway. So if I'm going to die, it's no great shakes. So that was pretty depressing. But fatalism is in there in the mix. Peer pressure. Well, we all know about peer pressure amongst teenagers to start, but peer pressure from work colleagues is quite a common factor in getting people to carry on smoking or go back to smoking, as with one of the Epsom subjects who had quit already some time ago, when 3 close relatives had died of smoking-related lung cancer. Not surprisingly, that scared her and stopped her smoking. Then she got this new job where they were all smokers, and they said, oh, come on, Susie, come and have a ciggy with us. And that was just too much, so she was back on the cigarettes. Lack of family cohesion, that's almost the other side of the coin from this gentle family pressure. For instance, the lonely middle-aged divorcee who has no supportive family, no family cohesion, he's going to find it more difficult to quit. And so far as the Epsom experience is concerned, the inadequacy of the risk score as a motivator. Risperidone is a good idea, but it came forth in the perceived importance so far as the subjects were concerned. So it's not as successful as we had hoped based on the New Zealand experience. On the other hand, some of the other motivators, like varenicline, like the counseling, like the weekly tests for carbon monoxide, they are labor intensive and very expensive, whereas the risperidone test is going to end up being dirt cheap, quite honestly, sooner or later. So as funding for smoking cessation drains away in health services, it may be that we depend more on something like the risperidone test to motivate our smokers to quit. However, I think it could be made better. It could be made more of a motivator. For instance, if we included a risk score for heart attack, that might help to beef up the motivational potency of this test. Now, I said I would say some more about PTSD as a complicating factor. Well, I've got another anonymized case history here. That is anonymized, I can't spell, sorry. This participant was a 23-year-old woman who worked as a stablemate. Her lifetime risk of lung cancer was a modest 20%, which is bad enough. She had quit at 8 weeks, and she had always seemed very highly motivated. She was very encouraging to other members of her group. However, she sustained soon after a compound fracture of her right leg when she was kicked by a horse in her care. As a result, she was stuck at home, off sick, with this injury for some time. All the pain, the nagging worry, the flashbacks that if I'd been more careful, this might not have happened, and going over and over it in your mind, and the pure boredom of being at home all the time is what started her back on the cigarettes. So at 6 months, she was back on 10 a day, and they had made it all a bit more bearable. So that is an example of not the sort of high-profile PTSD associated with a dramatic rape or shell shock, the classic things, but it is a form of PTSD that we're looking at there. And it's another case history where there was a more obvious example of PTSD that I won't repeat because it's a bit close to the bone. Okay, so let's look at the research to do with PTSD. And here we have what's called a survival curve. In red, you have Vietnam veterans in America who are plagued by nightmares, flashbacks to seeing their colleagues, best mate blown to pieces and things like that. Horrible, horrible, poor chaps. You know, it really was the worst form of PTSD. And it has been shown that with this sort of PTSD, or any PTSD, nicotine does inhibit the nightmares and the flashbacks. So no wonder they drop off the wagon, go back to smoking, so that at the end of this survival curve, there are only about 4-5% that are still non-smokers, whereas the control group have done rather better. It's more like 15% who have managed to quit. So that again is in the medical literature if you want to look at the details. So can fear of lung cancer make smokers quit? Unfortunately, as we've seen, it just isn't that simple and straightforward. Also, just to make life more complicated, humans seem to be partially adapted to the tobacco habit compared with other mammals. It may well have had certain health benefits for our Stone Age ancestors, not for us anymore, but for our Stone Age ancestors. And if you want to know more about this, what was going on with our Stone Age ancestors and their tobacco habit. They've written a chapter in this book. There's the link. It's an online book, and it's an open access, it's free access. So if you want to know more of that story, a fascinating story of the evolution and genetics of tobacco habituation, it's all in my chapter 2 in this book. And that's it. Thank you very much, and goodbye.